Hello and welcome back to the Relit Practice Podcast. My name is Stacey Steele and I'm a registered psychologist and EMDR consultant and somebody who's been in this work long enough to know the difference between insight and personal reckoning and how sometimes they go together. This show is for helping professionals like therapists, psychologists, social workers, counselors, and other allied health who are really good at what they do, who care very much, and who are also running on fumes. Here we talk about burnout, moral injury, our personal wellness, and what it actually takes to sustain clinical excellence with real frameworks, research, and real conversation. This episode is called Mythbusting Burnout, and I want to be clear and upfront of what I mean by myths. This is not some simple reframing or even a cheerful misconception that we politely correct. This is about something deeper, the core beliefs and bias that live inside our professional identities and spaces. And sometimes these are the beliefs and myths that tell us that what we're feeling must mean something is wrong with us, rather than something is wrong with the conditions that we're practicing in. And today we will speak them out loud. And maybe you might relate to this story. A few years ago, I remember coming home from my work in a community agency, and I was just so bagged. That structure of full caseload plus other duties, and I was just done. There were two crises that day. I remember very clearly. One was a suicide crisis, and after we addressed that, I had a safety plan, and I was booking them in for the next week. I realized I had nothing on the calendar for at least 3 weeks. So I had to put them in during a break. And that would mean that day I had no breaks at all, because then after that I was going to my part-time private practice. So that's one. The second crisis of that day was somebody was being released out of the hospital and into homelessness on a Friday afternoon. So it was try to coordinate somewhere for this person to stay. And keep in mind, I was their psychologist. I was not their caseworker or frontline worker because I didn't have one. And then by the end of the day, Friday, and I distinctly remember sitting in my driveway, the car was still running and I had nothing. I had sat there for maybe 10 or 15 minutes. The time just passed and I didn't have any recollection of it. And then when I finally kind of came to, I realized, okay, what's wrong with me? Why am I so tired? Why can't I just go into my house and start the rest of my weekend? And I need to suck it up, get it together. I can handle this. This is what I'm trained for. Put on your big girl pants and keep going forward. And so I did, until I couldn't anymore. So what I didn't say, and what I wasn't equipped to say in that moment, keep in mind, this is not about a knowing problem, is that I didn't feel I could say, my whole nervous system is just jacked. I am carrying this load that needs to go somewhere, but there is nowhere to set it down, and I've been feeling this way for months. Something inside of me was telling me I am not good enough, and if people find out, then they're going to know that you're not good enough either. So keep it under wraps and keep moving forward. And part of that didn't just necessarily come from core beliefs that I had, but were also reinforced by systems that I was working in. That burnout for some reason meant personal failure, and that the responsibility was solely on me to feel better. The research suggests that I am not the only one who has had a reckoning like that. There's a study in 2019 found that mental health practitioners are particularly prone to the cognitive biases that keep them from recognizing their own burnout. We tend to believe that our license protects us, that the title we have means that we're inoculated against burnout or distress, and we might read early warning signs as personal failures rather than a clinical signal that we need to attend to. We are, as it turns out, the professionals most likely to believe that we should be immune. And so that belief is what makes us the most vulnerable. Because of that, we are going to bust some myths about burnout. And the first one is myth number 1. Burnout is what happens when you care too much. There's a version of the story that gets told in different supervision and consultation rooms and in trainings, and the idea that if we care too much, or if we care too much, we're becoming enmeshed, or if we care too much, we don't have good boundaries, etc. And the rest of the story goes with the clinicians who burn out are the ones that were doing too much. They had too much empathy, they were too invested in the work, and it is the cost of caring. In some ways, saying that burnout happens when you care too much does honor the emotional weight of what we do. Because if it was just worksheets, then for sure, ChatGPT can take over our job. But we know it's not just about worksheets and validation. There is attunement, very real energy expenditure that goes into sessions. On one hand, it does honor that, but on the other hand, it is a story that puts the problem solely inside the clinician. Burnout, in reality, is not about caring too much. It is a work-related syndrome with 3 different components: emotional exhaustion, depersonalization or cynicism, and a reduced sense of personal accomplishment. It is the most empirically supported framework that we have on burnout. And the designers of that model were explicit that burnout is not a catch-all term for being busy or stretched or deeply invested. It is specific: exhaustion, cynicism, and feeling inefficient is what distinguishes burnout from general workplace stress. The part that the cares too much story really leaves out is the depersonalization or the cynicism. That's the distance that we have between clients that we maybe used to feel close to, or the satisfaction of the work. And it's not the opposite of caring, although it can feel like that. It is literally what our nervous system does when it's been in chronic stress without adequate recovery. We can consider that not caring too little, but as a physiological adaptation of the conditions that we're working in. So again, an adaptation, not a personal failing. The reason why this myth may have such staying power is that it lets us stop the conversation before it actually gets uncomfortable. If burnout's about individual passion and emotion and being overly invested, then the solution is individual restraint, putting in your boundaries, recognition when there is enmeshment or identification. If we believe that burnout is about caring too much, then we never have to ask the harder questions. The questions about why is our caseload the size it is? Why is our institution chronically underfunded? And why are these organizations asking us to carry their inefficiency for them? Maybe one way of looking at it is that burnout is what happens when the system that you're providing care within does not provide that care back. Okay, myth number 2. If you know about vicarious trauma, you're protected from it. There can be almost like a badge of honor about being able to carry like the heaviest load or taking on the most complex cases. And we can almost feel like we're untouchable, like we can handle it, we can take it, we can be the savior, we can be the hero. And it can also be seen by organizations like, well, Stacey can handle it, let's just give her this case, until all of a sudden we're left with a caseload that has super high acuity and no respite for ourselves. Going back to secondary traumatic stress, it is not a knowledge problem. It is literally a physiological process. When somebody sits across from you or you read in a file something very unbearable, our nervous system responds in ways that are not under our conscious control. We have mirror neurons, somatic resonance, even our implicit memory system that might relate some of their story to something that happened to us. And none of those unconscious processes consult our theoretical framework before they activate. Burnout among mental health professionals is shaped not only by job conditions, but by our personal history. That includes our attachment style and our developmental experiences. So I'm not saying that people who have had a history of trauma should not be in this work. I am one of them. We need people with lived experience in this work. So I'm not saying that. What I'm saying is that the research shows that having a conceptual awareness of how trauma might impact somebody, or maybe why we might be at risk, does not neutralize what chronic exposure does. And if we have that lived experience, we might be more at risk of developing burnout, because exposure does not care about a particular nervous. When we think about secondary traumatic stress versus burnout versus moral injury versus compassion fatigue, it's really sometimes difficult to delineate them from our current experience. And we use these words interchangeably when we shouldn't. Like compassion fatigue, burnout can be that catch-all. To pause and take a definition here. Secondary traumatic stress is characterized by almost like PTSD-like symptoms, like intrusion, avoidance, and physiological arousal following indirect exposure to trauma, hence secondary traumatic stress. Compassion fatigue is more of like a broader term that describes the exhaustion that comes from being in a caregiver role. Burnout is occupational specific, and it combines exhaustion, cynicism or depersonalization, and reduced efficacy. Moral injury is when you are forced to do or you witness an action that goes against your deeply held moral beliefs. So these can all co-occur, and they often do, but they are not the same thing. And treating them as interchangeable actually leads to an imprecise intervention. You can't self-care out of vicarious traumatization. What will protect you can be an honest self-assessment of what you're experiencing. And also getting real that if you're experiencing hypoarousal or hyperarousal, if you're experiencing intrusive images, dreams, thoughts, etc., and also maybe avoidance, then likely you are experiencing secondary traumatic stress. Awareness is at least the starting point. And myth number 3 is good professionals don't burn out. The myth that good professionals don't burn out can be the most dangerous belief on the list, because it operates entirely below the level of conscious awareness. And it could show up as an inner voice that other people are managing just fine, why can't I? Well, maybe I need more skills, then I wouldn't be feeling this way. Or I knew what I was getting into, I don't have a right to feel this way. So what does that inner and sometimes outer voice from somebody else, like an external critic? We get an inner critic because there is an external voice who told it to us first. So those voices do 2 things. The first is that it prevents us from recognizing the early signs of burnout. If admitting burnout means admitting that you're not good enough or not cut out, then why would we ever attribute what we're experiencing to burnout? We might attribute our fatigue to a bad week. We might normalize cynicism as being appropriately clinically pragmatic. Our psyche will work very hard not to see it so that we can keep moving, because if we stop, what does that mean? We're not a good professional. We're not cut out for this work. Okay, the second thing that the internal and external voices do is that it prevents us from seeking help. Because if burnout means that I'm not competent, then telling anyone about it risks my professional reputation, my standing, and also my own self-image as somebody who can do this work. There was more research done in 2019 that found that mental health practitioners frequently describe their own burnout as unprofessional. So that belief actively encourages self-blame, denial, and delayed intervention. So if my body is doing this automatic thing that I don't have conscious awareness of, but I'm exhausted, and if I label that burnout and it means I'm unprofessional, then how can I keep doing this work? Another study in 2025 found that in nurses, higher burnout was associated with more negative attitudes towards help seeking. In some ways, like, burnout reinforces that stigma, and those that need the most support are the least likely to seek it. So let me just tell you this. Burnout does not mean you're bad at your job. It does not mean that you're not cut out for this. It does not mean that for some reason you should quit your job and go open a bookstore, which actually sounds kind of nice, but it doesn't mean any of that. It means that you've been operating in conditions that exceed your capacity for recovery, and you've been operating them for long enough that your whole system is adapted in ways that impair your functioning at home and at work. That has nothing to do with your character. That has nothing to do with your professionalism. That is pure physiology that we attribute a belief to. And more often than not, it's more indicative of the system that we're working in than who we are as a human being. And I have to say, in the hundreds of conversations I've had with other clinicians over the last many years, some of the most skilled and professional and educated people I know have burned out, some of them more than once. And that skill does not protect them or protect any of us from overload in a structure. And myth number 4. So this one is, I don't want to say I have beef with it, but it kind of hits home. So myth number 4, self-care will fix burnout. So I worked in another organization that had a whole workshop on self-care and burnout, compassion fatigue. It was actually really great. But the result was that each employee had to fill out a self-care plan, including warning signs when they're getting into risk zones, so to speak. So that sounds all fine and dandy. And it was actually a very informative exercise. But the one thing, well, actually 2 things, but one of the things that was left out of that was institutional responsibility. The second was that we actually had to hand it in. We had to be accountable to our colleagues and management about how we were enacting our self-care plan. So if we were burning out or feeling a certain way, are you doing your self-care plan? And I also want to be careful here because I do believe in embodied practice. I'm a yoga teacher. I'm going for my yoga therapy certification. And I take our somatic regulation very seriously. Rest, movement, connecting with other people, being creative, playful, those all are important. And I will not be the person telling you that your bubble bath that you have on Friday nights is meaningless. Please keep doing that. But I will be the one to tell you that self-care cannot compensate for high acuity caseload, and self-care cannot compensate for workplace policies that prevent patients from getting the help they deserve. When we sell self-care as a solution to burnout, whether we mean to or not, just like in my old workplace, we place the burden of a systemic problem on the individual. So consider what we're actually asking people to do when we say self-care will cure burnout, is we're asking them to disregard a caseload of 40 high acuity trauma clients, a documentation system that's designed by somebody who's never sat in a session. We are asking them to disregard inadequate supervision. We're asking them to disregard pay that doesn't reflect the role that they're in. And we're asking them to put all of that aside and take on that load by recommending them that they keep a gratitude journal. No amount of journaling will resolve that because the math ain't mathing. What is so interesting, when I was researching for this part of the pod, I was looking at the history of how the concept of burnout has shifted. The concept of burnout first came from a systemic critique of exploitive care conditions in healthcare, and then morphed into a tool for individual self-management and to enhance productivity. In that analysis, again, link in the show notes, it totally obscures that the structural problem that produces burnout in the first place. In that analysis, that shift of the concept of burnout conveniently obscured the structural problems that produce burnout in the first place and attributed it to the individual. In 2024, there was another study that flagged very weak evidence behind the claim that individual level interventions are enough for primary treatments when structural and organizational factors are doing most of the damage. So that self-care assessment that We had to have it in my old workplace. It was a good exercise, but it actually did not offer enough intervention to even prevent burnout in the first place. Again, do the yoga, the journaling, go to supervision, do all the things. And if you're still exhausted, please know that you're not doing it wrong. It's because that is the wrong intervention for the problem. Self-care is a support in your burnout recovery. It is not the solution. And that brings us to the last myth that I'm going to cover today, is that burnout is just stress. It will pass. Okay. So this one is something that can be a little more insidious. It's because when we're in the thick of it and we're experiencing maybe some of the signs of burnout or secondary traumatic stress or moral injury, we get into this headspace of like, I just need to get through this week, or I just need to get to the next vacation. I just need to get to Friday, or I just need to get to 4:30. And it keeps us in the same cycle long after the problem started. And this is why, because burnout is not an acute stress response. A stress response is mobilization that our system activates in response to a demand. When the demand resolves, then recovery follows in a relatively predictable arc. Think about a baby crying who is hungry. They're up from their nap, they need their diaper changed, they need to be fed. Their caregiver comes in, picks them up, pats them on the back, changes their diaper, gets them clean, feeds them, and they're fine. We're not so much unlike that baby. We're not unlike that baby. But when we're in that crib and we're calling for somebody to help make us more comfortable or to feed us or to help us with our needs, and we're not getting that, then that acute stress never resolves. And it might turn into burnout. And burnout is exhaustion that sleep or rest doesn't repair. It is that cynicism and depersonalization, even during moments that you used to find meaningful. So the distinction between burnout and a stress response is that burnout symptoms will ebb and flow, which can create the false impression of recovery. So we might have some good days. We might feel really engaged sometimes. But in the background, we may still be exhausted. It's just that we might have a lighter week or a lull, but it still exists. Normalizing serious distress as just stress is one of the ways that also prevents help seeking and normalizes the experience as something that's going to resolve, when in reality it continues on, maybe not at the same level as it does day to day, but it's still there. Something else that isn't talked about enough, in my opinion, is that burnout can significantly overlap with major depressive disorder. If you think about it, there's fatigue, social withdrawal, reduced engagement in activities, maybe numbness and flat affect, and feeling a loss of meaning. And that much of what we label burnout actually can also meet the criteria for a diagnosable mood disorder, which really, if you think about it, if clinicians are hesitant to seek help for burnout, how many of us are experiencing depression in addition to that and not seeking help because we think it's just stress? One action you can do today is to begin to track what you're feeling, whether or not you use a formal measure like PHQ-9 or the Professional Quality of Life survey, or even if you begin to write a line in your notebook or use an app, anything, but begin to track your experience. And when we begin to notice that, hey, some of these symptoms are persistent, and some of this is not going away, even though I took a vacation, even though I had my supervision, even though XYZ, then that's something to look at closer. Different ways of doing that. I personally use the Green Space Health platform for my clients and outcome tracking, and I actually use it for myself too. There's another app called Bearable. It has a cute little teddy bear on that. It's made for people with chronic illness, but what I like about it is that you can track not just your physical and mental health symptoms, but also factors that influence it. So you can get really involved of tracking outcomes and using cool apps and data. And I'm kind of a data nerd, so that's right up my alley. But if you're already tired, that can be a really big ask. So consider even something simpler. Maybe you have a post-it note that you put on your laptop and you rate your energy at the end of the day before you leave. And then maybe after 30 days of doing that, you can see, hey, I'm not getting very many 8 out of 10s at the end of the day. In fact, as I track and move on, I notice my energy is staying the same, if not lower. And so that's information that you can take and do something with. And maybe it might motivate you to seek help. We are in a field that is trained to understand that human suffering can be met with compassion and create something transformative for a client. And we are simultaneously in a field that doesn't apply that same belief to the people working in it. So the labels that we've named today, that burnout means you care too much, that knowing protects you, that good professionals don't struggle, that self-care will fix it, and that it's only stress that will pass, those beliefs didn't arrive to us by accident. They came from professional cultures, training institutions, places that normalize overwork, and maybe systems that need us to be more functional than they need us to be whole. So I'm going to give you the actual myth. The one that might underlie all the other ones is that we don't matter. Because, my friend, you do. You know that feeling when you finish your last session and you can't quite find that line between you and work anymore? Or maybe you're still competent, clients are still showing up and getting good care, but something underneath is like draining your battery. That's a place where a lot of helpers and therapists come to me from. And so I built the Relit practice. It's a program grounded in research, lived experience, and the reality of the systems that you're working in. I personally understand the weight of burnout because I have carried it too. And I know what it's like to give everything to our clients while feeling like we have nothing left to give for ourselves and to wonder, is this just how it is? This program is 12 weeks. And in those 12 weeks, we work through what's actually depleting you more than the symptoms, but we look at the structures that need changing, whether you're working in private practice, community agency, or public health. We rebuild so that you can walk away with the ability to do meaningful work without having to recover from it. This September founding cohort opens for enrollment in July with special pricing for the first 8 people. You can join the waitlist at www.relitpractice.com or even book a free Practice Sustainable snapshot with me first, an opportunity to spend 20 minutes with me, and we look at maybe one thing that you can change today to feel even 10% more sustainable. You can go to the link in the show notes to book that. If something in today's episode landed for you, I would love to hear about it. You can find me on Instagram, on my website, and every month at the Reset Circle, which is a free monthly peer gathering for clinicians. Take good care of yourself, my friend, not because it makes you more productive, but because you matter. See you next time.